Well, good morning or good afternoon, everyone. You should be able to see my screen in just a moment. This is Joy Burkhardt with 2020 Mom, and we're thrilled to be presenting another Innovation Award program, this time the North Shore Moms program, which won the award for honorable mention in the Innovative Programs in Care session. And before we jump in, I want to ask and suggest a couple things. We first want to ask each of you, there's about 25 of you on the line now, to say hello using the chat feature of your GoToWebinar control panel. So if you can say hello and maybe let us know where you're located or your clinical background, or if you're just a champion for maternal mental health, a little something about you. All right, and I see that Motherwise is with us. If the chat feature isn't working, you're welcome to use the question feature and let us know again where you're located. Jacqueline, it's nice to see you again. So go ahead and use that question feature. All right, well, we're going to go ahead and get started. And we are recording today's session, so others are likely going to be listening later, and welcome to all of you as well. And thank you for, we see some more comments coming in, so we'll take a look at who else is on the line here in just a moment. I'm first going to introduce Jo Kim, Dr. Kim. She is the director of the North Shore University Health System Perinatal Depression Program that we're going to hear about today, and a clinical associate professor at the University of Chicago School of Medicine. Dr. Kim earned her PhD in clinical psychology from Northwestern University Medical School in 2002 and completed her postdoctoral fellowship in health psychology at the North Shore University Health System. She's done a lot of research and program implementation, which we love. That's what we'll get to hear about today. And her research has focused on perinatal depression screening, barriers to mental health care for women, and use of mobile health technologies to improve detection and treatment of these disorders. So Jo, it's such a pleasure to have you, and really to get to see a program who has brought together so many different aspects, addressing so many different challenges in our work in bringing care and detection of these disorders to women. And so we're thrilled to have you, and congratulations again on the honorable mention for your program.
Thank you so much, Joy. Thank you for that lovely introduction, and it's my pleasure to be here. And good afternoon or good morning, as the case may be, to everyone else on the webinar.
Super, and I am just going to quickly let you know who else might be on. We have Brooke from San Luis Obispo, California. Welcome, Brooke. We also have a case manager with a large insurance company. We're so glad that you're with us, Michelle, working with high-risk patients, pregnancy, and Michelle's based in Pennsylvania. So glad you're with us. We have Holly from, hold on just a moment. A program from Any Baby Can. Quite a few folks from Department of Public Health in a California market. Savannah, someone from Savannah, an LPC. We also have someone here from another insurance company. We are so glad to have you from Texas. I recognize so many of these names. We also have someone who just moved from Utah to Iowa, who is an LCSW, a clinical social worker. We have a lactation consultant with us on the line. We have someone from the Midwest Center for Women's Healthcare, an RN. Welcome, Marianne. So many great folks. Another person from Texas, someone from Arizona, a midwife. Welcome. Someone from a family collaborative in Montana. Super. Well, we'll go ahead and get started. Welcome to all of you. And it really is a testament to how diverse and important this work is and that so many of us in clinical fields or community-based programs are touching moms and interested in innovative solutions that are working. So it's a pleasure again to have you, Joe. We're going to go ahead and jump right in. You'll get to see a picture of both myself and Joe on the next slide, but I do want to point out before we move on to the next slide that you can see where you can find more information about all of our Innovation Award programs here on the 2020mom.org website. On the screen here, you can find that path. And then let me quickly show you who we are. There I am again, the executive director of 2020 Mom, and there's a picture of Dr. Kim, and we're going to hear from Joe in detail today. And let me go ahead and leave that up. The way we have begun these webinars is really to keep them like a fireside chat. And so I'm going to be asking Joe questions throughout our session, and we'll take a few breaks for questions throughout the remainder of the hour today. And we welcome all of you to submit your questions just like you did through the question feature. Pretend like we're all sitting around the fireplace together and just chatting about this program. There's also information, a handout about Joe's program. If you want to follow along, you can open up that handout. It will also be, it's in the GoToWebinar control panel. It'll also be available on our website by tomorrow in past webinar recordings on our website. All right, so we're going to jump right in. And Joe, if you don't mind that I call you Joe, I feel like I know you well enough to call you Joe. Super. We'll go ahead and get started. And I think it's first important to hear about, so many of our programs, the programs that are starting and cropping up across the U.S. really start because of a tragedy. And I think there's an important story to hear about Jennifer Mudd and how your program got started. So if you don't mind, if we can start with that story, and then we'll get into the key components of your really comprehensive program.
Yes, absolutely. And I'm glad we're actually starting on that note because it's something that we who work in the program like to remind ourselves about on a frequent basis, that we are a program that was born out of one family's tragedy and their desire to spare other families from having to go through what they went through. So we were founded in memory of a young mom named Jennifer Mudd. She tragically lost her life to postpartum depression back in 2001. And Jennifer had happened to have grown up in the community where our hospital system is based. And so her family essentially approached our system and said, we've just gone through the unthinkable. We want to really sit down and brainstorm about what we can do to help prevent other families from having to suffer in the way that we did. And they also recognized they were a family that had a lot of internal and external support and a lot of resources at their disposal, and yet they still lost their daughter. So I think in their heart and in their mind, there was also a recognition that a lot of women families out there face even bigger barriers than they did.
That's super. Thank you. And we will get to funding in a moment. I know a lot of folks initially want to hear right away how you got started and where funding came from. We know that your program got started because of Jennifer's loss. And Joe, I think instead of waiting, we will just, if you can touch on that, I know that there's some more detail we can talk about in the end around program funding, but if you don't mind, since so many folks, I think, on the line, when we're talking about development of these programs, which is really what this Innovation Awards program is intended to do and inspire, is help people take best practices and launch them in their own community. So if you don't mind, let's touch on that for just a moment. We can go into more detail at the end of the session if need be.
Sure.
Talk to us about funding.
So our inception funding, we were very fortunate to have a generous gift from the Mudd family in the beginning that enabled us to sort of, group ourselves together, form a multidisciplinary team, work in collaboration with the Mudds, and really design sort of what the program was going to look like and begin to implement its key components. Since that time, we've turned to a variety of different resources to secure sustainability funding for the program. The Mudds have continued their generosity to us over the years. We've also received funding from a number of other private community and family foundations. We've secured some funding from the Illinois Department of Human Services, and that's related to the service we provide to publicly funded patients within the state of Illinois. And then we've also received some funding from our own health system because they've recognized that what we do is unique and that this program being based here is really a differentiator for the hospital system, and that they want to support it as well. So it's really a variety of sources that kind of keep us afloat. We operate on a very kind of skeleton crew level. We have 2.8 on-site staff, and then all the rest of the work of the program is done by resource staff who are essentially used on an as-needed basis, and that really helps us keep our costs contained.
Fantastic. I'm sure there'll be some additional questions that come up about that as we progress, but let's go ahead and turn to your program. And it sounds like the program was designed probably in phases. I'm guessing, Joe, you can walk us through a little bit of this in just a moment, but it's very much a multifaceted program. I think often those that know a little bit about your program think about the Mom's hotline, but it's much more than that. And if we can start first with usually, where people start and think about is screening. And so if you can talk to us a little bit about screening and detection, and then provider training. I think we'll start there, and then we'll hit on the other components of your program.
Sure, absolutely. And one thing for context that I just want to put out there is, in our initial strategic planning meetings with the MUDs and with the multidisciplinary team that kind of designed the program, we had an initial debate, do we want to be kind of a direct service provider and sort of try to be a one-stop shop where moms and families can get direct clinical service, or do we want to try to cast a wide net and impact as many women and families as possible? And we kind of chose the latter route. And in doing that, we also made a commitment to partnering with community resources that were already out there or developing community resources where they weren't there to make sure that we could adequately meet the needs of everyone, all the needs that would be uncovered through the activities that we propose to undertake. So, as you mentioned, Joy, universal perinatal depression screening is one core component of our program. So, since our inception, for about 15 years now, we've been screening all pregnant and postpartum moms who get care through our system. And our system does about 5,000 deliveries a year. And so we're screening women during pregnancy, we're screening them postpartum, and then we've got some of our pediatric care sites screening moms as well. And essentially, any woman who screens at risk gets an individual mental health outreach call. And that's just going to be to assess a little bit further what her symptoms are, what her stressors and other situational factors are, what kind of support she's got on board, any mental health history that might be relevant, all those kinds of things, with the goal of putting together kind of a tailored resource and referral plan for her. Right now, the screening tool that we use is the Edinburgh Postnatal Depression Scale. We've been using that for the past 15 years. And we are, I'll talk about this more in the call later, I'm sure, but we're actually in the process of transitioning to using a really innovative computerized adaptive testing technology that we think will enhance our screening program going forward.
Great, we can't wait to hear about that. Yeah, tell us about training. How did you train staff?
So, we realized when we set out to kind of do this screening that we weren't going to be able to just say to, all of these care sites, guess what, guys, starting tomorrow, you've got to screen all your patients. We really needed to be able to provide them with appropriate training, appropriate technical assistance, support, and, just kind of access to backup so that they would feel like we weren't asking them to, open Pandora's box and then deal with the contents. So we're really saying, we're encouraging you to do what's right by your patients, and we're going to provide you with all the tools you need to do it. So initially, when our program started, we actually went out to all the care sites that were affiliated with our system, and we did trainings with the physicians, nurses, and front-end staff, and really tried to educate them about perinatal mood disorders, about the benefits and rationale for screening, about the Edinburgh, about how it's used, and then about what we would do with the results. So just really reassuring them that, you're responsible for giving this screen. You're not responsible for figuring out what to do from there. You're just responsible with getting the patient linked with us, and we'll take it from there. Since that time, we do, periodic booster sessions with our collaborating sites. We've also really committed to doing what we can to equip the next generation of medical providers to be able to recognize and maybe even treat these disorders. So, we do frequent training with University of Chicago medical students who rotate on our campus. We train the OB and family practice residents, and we've also engaged with we're part of a perinatal network, so it's sort of a network of hospitals, and we do a lot of training with nurses through that. And then we also sponsor a couple of grand rounds a year in different disciplines just to provide more ongoing education and updates, maybe bring in some external speakers or feature, what's new in the literature.
Okay, and we're going to pause for just a moment because you've hit on a couple really critical points, in my opinion. One is, and again, such a comprehensive program. One is this notion of, and I think we mentioned earlier that so often we want to rush to require screening, but you recognize that providers needed support in more than one way, not just training and education on these sort of baseline disorders, and how to use the tool, but also really once they had a positive screen to be able to turn that over to a group of experts that could do further assessment, help find referral pathways, etc. So I wanted to hit on that. And before we move off of that, Joe, I know your PowerPoint slides address a treatment plan. So can you talk a little bit about what that looks like? And is it the OB provider that's creating the treatment plan? How does that part work?
So essentially what's happening is, the mental health clinician who's reaching out to the woman by phone after she's screened at risk is really working collaboratively with the woman to develop that plan. So the mental health professional is sort of outlining what all of the options and resources are, and then sort of meeting that woman where she is in terms of what steps she's ready to take now and what she might be ready to take later. One thing that we've really benefited from over time is probably, 7 or 8 years ago, we gained the ability to securely email women when they've had contact with our program, and that enables us to, while protecting their privacy, without violating HIPAA, we're able to actually send them all of these resources and referrals. So that means we can include links to provider websites or to resources like Postpartum Support International, other reputable sites if they want more information or education. And it also means that we're able to kind of include resources that a woman might not be ready to take advantage of now, but we want her to have in her back pocket later. A lot of women, I think many people on this call who work with this population know a lot of moms are reluctant to consider medication. They're ambivalent, they're reticent, but, it could be something that could benefit them. So just saying, I know you're on the fence now, but here are some great resources if you decide this is something that you want to move forward with. And so, we really try to provide them as much information as possible, both based on steps they're ready to take now and additional things that we're recommending they consider. Then we're looping their physician or nurse midwife or whoever's providing their OB care, we're looping them in on what that plan is so that they're aware as well and can help encourage the patient to follow through.
Great. That was going to be my next question around is there some sort of ongoing case management that your team provides to check in with the patient, or is it the OBGYN's office that might be responsible once that treatment plan is shared, developed and shared with the OBGYN?
That's a really good question, and my really good answer is it depends. We were originally designed to be kind of a single contact model. The idea was that we would have this one outreach phone call following the at-risk screen, we'd put the plan together and turn it back to the OB. What we discovered over time is that that doesn't always work, and some of the reasons why it might not always work are, if this patient is pretty severely symptomatic and might need a little more assistance or encouragement or warm handoff than an OB is able to coordinate if we're dealing with very specific referrals that require facilitation. So, I would say many of our outreach to at-risk screening women is still kind of that single contact model, but then we do have those occasions where we're doing some follow-up, whether that's by phone or email or through, circling back with the physician. Our mental health provider network in the community, we've known many of these providers for a decade and a half now, and we have close relationships with them. So a lot of times we will kind of reach out and say, hey, this patient really could, stand to be seen sooner than later. Can you squeeze her in? And so sometimes we'll do that little bit of extra facilitating, and then, just have some follow-up contact based on that.
Very helpful. I'm sure we'll get some questions along the way about that, Jo, but thank you for going into that important work, and it sounds like it's very much collaborative, and you adjust kind of as needed, even if it wasn't in the initial plan to provide that type of outreach. You will as needed. So back to provider education, another really important point that you mentioned, and it seems like you've really taken the approach of educating providers in a multifaceted way. I think what I heard you say is that there's some baseline provider education that's provided to OBGYNs, what I read in your slide, OBGYNs, RNs, and family practice providers. There's baseline education for those providers in the health system. Mm-hmm. And you also, what's really remarkable, I think, and so critically important, and I think our movement is really looking to do this better, and so we should talk some more about this, Jo, is the medical school curriculum and training that's been developed and implemented. So you've moved upstream to catch people while they're in medical school as well, and maybe those students aren't just in your medical system, but getting educated and going into different parts of Illinois. Can you just hit on that one more time and tell us more about the medical school curriculum?
Yeah, absolutely. So, these are medical students who are doing an OB rotation, but they could be pursuing any specialty under the sun, and they could be going on to practice in any location. So we really view this as an opportunity to kind of spread awareness broadly. The training is really focused on a few key points. We really try to emphasize detection and recognition of risk factors and ways to educate patients about treatment options versus getting into the weeds of, anything beyond that, because we recognize that, anytime I'm sitting talking with a group of 20 medical students, maybe one of them is going to go into OB, but, one might go into internal medicine, one might become a hospitalist, they might enter other fields where this training and knowledge, if it's in the back of their mind, is going to sort of leap to the forefront when they see or hear something that rings a bell. And that's really the intent, is just to sort of plant that seed so that they have a few kind of key pearls they've taken away from that lecture that they can then, implement later. And we try to equip them with, resources as well, just to help them going forward in their practice, things like LactMed, if a patient should have questions about medication and breastfeeding, or, the Mass Gen website that provides such good updates about, the latest literature. And, for anyone who has any level of interest, we want ways to keep them engaged and keep them learning in this area.
Great. Very helpful. I know I'm taking some notes on what you've shared. So let's get back then to this like overarching program and the pockets of programmatic work that you're doing. We hit on first the screening component that you utilize the Edinburgh or EDPS to screen, and you have educated providers. And now let's go back to really this case management component. So once there's a positive screen, it comes into the mom's line. I think that's the pathway. Tell us what the pathway is like, and then hit on this community resource component one more time. I think you did hit on it already, but let us know kind of how do you find these community-based resources once a mom comes in with a positive screen, and then also talk to us about the other pathways that families can come into you. So I think even if they're not screened through your system, that moms may find you, or providers may find you who are not inside your system.
Right, right. I'll actually address that last part first because it will help set the context for everything else. So basically, moms find their way to us in several ways. One is through the screening program. So they may be screened in their obstetric care provider's office, and then we get those screens and we outreach them. Sometimes we also get calls from physicians within our system who are saying, I'm concerned about my patient. This is what she's reporting. This is what I'm noticing. I didn't screen her, but can you call her? And if they're a physician within our system, then we're able to do that. The most common way people outside our system come to interface with us, though, is through the Moms line. That's our most public, outside of our health system piece of our program. And a lot of people find that by Googling. People find it because a number of hospitals in Illinois included in their discharge packets. Many WIC offices in our state distribute the information to their recipients. So, moms may learn about the Moms line through many different ways, but that's another major way that people come to us. And, our health system primarily serves northern Cook and Lake counties in the Chicago area, but the Moms line gets calls from all over the state and all over the country, and even internationally. I think we'll talk a little bit more about the Moms line later, but that's really sort of the way a lot of people funnel in to interface with us. However, when we started, we didn't really anticipate that. We were viewing ourselves as kind of a local resource. And so how we started off building our resource network was really sort of through networking. There was this group of stakeholders sitting around the table, and we thought, okay, who do we know out there in the community who does this work or who has interest in this work? That led us to various therapists, psychiatrists. Over time, we realized the needs of this population went really far beyond mental health treatment. And so we really started looking to add more home visiting programs, doula services, lactation consultants, other types of resources to the resource list as well. So our resource list today, I can't share it with anyone because it's almost embarrassing. It's this very unwieldy spreadsheet that has, 12 different tabs for all different types of resources. And those of us who work with the program know how to sort and filter it, but to anyone else, I think it would look like chaos.
Right.
However, it's working for us, and it helps us be able to locate exactly the types of resources that any given woman needs. Early on in the program, we also did a programmatic evaluation because we wanted to see, okay, we think we're doing good work here. We think we're giving people what they need, but we want to make sure. And one really sobering thing we discovered was that the vast majority of women who we were providing with referrals were not actually linking with treatment. They were getting the referrals okay, and they were just facing a lot of different barriers to care. And so we then really focused on, okay, we need to tailor these referrals a lot more carefully. We need to really assess with these women, what's most important to them. Is an insurance match most important? Is a geographic location most important? Is a provider racial or ethnic background most important? And we really needed to sort of do whatever we could to make sure that we reduced as many barriers to care as possible. We also, a number of really great support groups have started in our local area since our service began, and we've really strengthened our relationship with those groups as well, because a lot of times that's the front door a woman is first willing to walk through. You might not be able to get her to go see a therapist, you might not be able to get her to go to a psychiatrist, but a support group just sounds a little easier, a little less stigmatizing maybe. And so we work closely with those groups as well to sort of say, okay, this woman's ready to come see you. We've loaded her up with other stuff, but maybe you can help encourage her. We also, because we have gotten calls from so many other locations around the state and around the country, early on in our history of being funded by the state of Illinois, we actually were funded to put together a statewide resource directory, and that then got folded into our Department of Child and Family Services statewide provider database. So that's actually a resource that we are able to access as well if we're looking for resources for callers who may be in downstate Illinois or outside of the Chicago metro area. For out-of-state callers, we rely really heavily on the SAMHSA Behavioral Health Facility Locator. We rely on the PSI website and reaching out to some of those state and country coordinators. And sometimes we're really just Googling because, we kind of know what we're looking for in terms of, expertise that an individual has. And, oftentimes we can help someone navigate finding resources just a little bit more knowledgeably than they might be able to do on their own. And also, just taking that burden off of them, because if you're already feeling depressed or if you're already highly anxious, the thought of just, opening a search engine and typing in therapist can seem overwhelming, but having us to kind of help navigate that process can be helpful. And we've even had occasions where, women have sent us a copy of, the providers who are covered by their insurance, and then we'll kind of check it against lists that we have access to and try to figure out, where the overlap is and who might be the most viable referrals for them.
Great. Thank you for that, Joe. We did get one question that came in. I'm going to go ahead and pause to take it. And it's around clarifying the FTEs that are needed to do both the internal hospital system work, which we think you said 5,000 births in your system, and then staff to train and help with screening implementation. And then there's also this additional volume of patients that come in through the mom's line. And is it the 2.8 full-time equivalent, FTE bodies that support all of that work with additional, I think, contract behavioral health providers that staff the line? Can you just help us wrap our head around, sort of if someone were to try to use the staffing model based off of the work that you're doing to implement it in their region or state? We're just trying to understand that. Is it the 2.8 for all of it, or just your hospital system, et cetera?
Okay, good question. So the 2.8 FTEs is for, operating the screening program, which includes kind of the provider education piece, as well as the outreach to at-risk screening women. And it also includes the supervision of the hotline staff, the maintenance of the resources, and the research component. So that's all of that. Then the mom's line is sort of a bit of a separate entity, and we have about 15 to 17 resource clinicians who cover that. So these are master's and doctoral level perinatal mental health clinicians, and they are essentially at any given time, one of them is on call covering the mom's line because it is a 24/7 resource. We have someone who's available to take a call, anytime, day or night, and then they are compensated at a clinical rate for calls that they receive, and then they're compensated at sort of a per shift on call rate for just being available to take a call if needed. That resource staffing plan has given us a lot of flexibility, though, because as our call volume has increased over time and our screening volume has increased over time, we have sometimes been able to sort of triage off some of the at-risk outreach calls to members of this resource staff. So they're really used in a variety of different capacities. And we've also used them, for instance, some of them have actual interest or background and experience in doing provider education and training. And so we may get a training request that the on-site staff don't have capacity to meet, but we might have a resource staff who's happy to go out to this agency and give a presentation, or who's happy to meet with these pediatricians or whatever. So we really, those resource staff, were able to use them quite flexibly. And, they're really, they're practicing, at the top of their licensure, but also really just on an as-needed basis. I think that has been key to the sustainability of the program, because especially we wouldn't have any way of operating a 24/7 resource if we didn't have that staffing model.
That's really helpful. And Joe, I think we're going to have some folks that are interested in seeing that, and anything that you have written down or be willing to write down for us around the staffing model and exactly what you described, but just something that people can touch and feel and circulate to help them think about how to implement a model like this. It would be helpful if you could share that with us. Would you mind doing that?
No, absolutely. I think I'll need to update something I've created previously for another use, so I can get that to you at some point after the webinar.
Great, great. And we'll get that posted, everyone. And I think we have Stacy on our team. Stacy will ask that once we get that resource, we email everyone who's registered for this webinar and make sure that they know it's available. We'll put it on our website as well. So great, Joe. Thank you for that. And then final piece of clarification around staffing, is it you then, Joe, who oversees the whole program that manages all of the staff and both the line and the training, and it seems like a fairly big job. Is that how it works? It sits under you?
Yes, and so I'm included in that 2.8 FTE. That's including me.
Great, perfect. Good. Well, we can't wait to see that plan. Thanks for being willing to share it. So much to talk about relative to your program. I think what we will move into now, and Joe, let me just ask, is there anything more you want to share about the Moms line? I do think it's phenomenal that you intended to kind of staff and do this work in a couple of counties and now service really the whole state, but also don't turn away someone outside of the state. So thank you for that work, since we know it can really be a challenge, as you pointed out, for moms to find support.
Yeah, and I think, when we started, we didn't even really have a concept of what a unique resource it would be. And the way it was supposed to be set up is it was only supposed to accept incoming calls from 5 area codes. And it was actually a technical glitch that started allowing other calls through. And then we met with the hotline staff and said, oh, don't worry, guys, we're going to get this taken care of. We're going to narrow it back down to our service area. And they felt very strongly, no, we can't do that. We're really able to help these women who are calling. They have nowhere else to go. Even though they're not in our geographic service area, we can help them in many other ways, and we don't want to limit where the calls can come from. And so it was really by popular demand of the staff that we decided to just, let it go, and it's kind of unfolded from there. And, I think we haven't really looked back since that happened. And, one thing I will also say is occasionally we do get calls from callers who are not perinatal in any way. And, we're never going to give a caller a message of, we can't help you, or we're not the right resource. We're always going to do what we can to help them and then guide them toward other resources that may be even more helpful to them. So we never want someone to call us and kind of get the message of, we can't help you. We always want them to get the message of, we're so glad you called. We can help you. Let's see what we can do.
That's phenomenal, and thank you. I know others on the line are agreeing, so thank you, Joe. Let's move into, you mentioned sort of the call routing technology and sort of the glitch with accepting area codes, but I think this is a great segue to talk for a moment about technology. And if you don't mind starting with, what technology did you initially need? And we heard about call routing technology for the Moms line. And then to talk a little bit more about some of these other innovative solutions that you hinted at earlier, but it seems to be kind of a core component of your program work, is to look at how do we streamline and make this more efficient and even more effective as we go, and not just settle with a good program, but continue to try to make it great. So love to hear first about, again, if someone were to start a program like this, what should they be thinking about around technology, and what did you start with?
Okay, great. So, in the beginning, the two main things we needed to figure out is, okay, we want to have a hotline. How are we going to make that work? And also, we need a way to get the screens that are being administered in other locations. How are we going to get that to work? So as for the hotline, a lot of hotlines operate out of call centers, but we knew from the outset that we didn't have the budget to afford a physical space, much less pay people to sit full time waiting for calls to come in, nor did we anticipate a call volume high enough to really justify that. So our director of communications here at North Shore at the time really helped us do research into what technologies were out there. And we started off with a different call routing system that had some limitations. And then several years in, we switched to the current system that we used, which is called remote access call forwarding. So basically, this just enables any user in real time to route the 866-364 MOMS number to the phone of their choosing. It gives us a lot of flexibility in terms of our staffing. It enables us to, the change of shift is a very smooth and efficient process. If one person is on and they get caught up with a caller in crisis, someone else can log in and take over the incoming calls. It really helps us to ensure the 24/7 coverage with minimal staffing costs and minimal sort of overhead.
Talk to us a little bit more about that, because it does seem to be a very critical piece of the success of the MOMS line. So remote access call routing, and it allows you to route to a particular telephone number. And then if someone's on a line when another call comes in, it sounds like it will notify another on-call provider who would pick up that call and answer it. Is that?
It's not quite that elegant, unfortunately. We wish it could do that. So what happens is, we have one clinician on call staffing the line at any given time. And, sort of our standard operating procedures are that if you're on the phone with one caller, unless that caller is in acute crisis, if another call comes in, you sort of politely explain to the first caller, I'm the only person staffing the line right now. I just need to, make sure this other caller is okay to wait for me to call them back and sort of switch over. If there is a caller in acute crisis, then we do have sort of standard outgoing voicemail greetings that all of our staff are required to use that essentially, let the caller know they've reached the right resource, explain that they're speaking with another caller now, and encourage them to, leave a message so that we can get back to them as soon as possible. The proliferation of texting has really helped us because now the worker who's on call, who may be tied up with another call, can text me or can text, others on this team and just say, I'm on the line with an acute caller, just missed a call from this number, can you call back? And so it really enables us to not even necessarily have to wait until that person is off the phone and can retrieve their voicemail to kind of follow up with those calls that we may miss. Our aim is that all calls would be answered live, and it's a very, very infrequent occurrence that two calls come in at the exact same time. That's something we are always monitoring because we do have to keep in mind that if our volume reaches a certain level, we probably would need to double up on staffing of each shift just to ensure that calls are not being missed or, going to voicemail too frequently.
Okay, got it. That's great. We did have a few people comment and ask about the name of the technology again, and say that just all sounds phenomenal, and the staffing plan will really help them as well. Let's talk a little bit more about the other technologies you have been exploring and or have adopted since your inception of the program, in 15 years ago now, Joe? Thank you.
Sure. I think we are part of a health system that's very innovation focused. And, our system was one of the first to fully adopt kind of the entire Epic suite for electronic health records, and has always really tried to be kind of at the forefront of what technology can do for healthcare. So as a natural extension of that, our program has also been very focused on how can we harness technology, and in particular, how can we harness it to help improve our program, to do what we do better, and also to help overcome barriers to care that we're still seeing among many of the women and families that we serve. So I can just speak a little bit about some of the things that we've been doing kind of in more recent years that are innovative in this way. One thing that we've done recently is we piloted just to see would it be feasible and acceptable to screen women by smartphone. Instead of them coming into the office and being handed a pen and paper screen and asked to complete it in the visit, what if we push that screen out to them in a text message that they got on their phone, and they clicked on a link and they were prompted to complete a screen? And so we did that just to figure out, would women do this? Would it be acceptable to them? How would physicians feel about it? And then coupled with that, we also looked to see, what if we just did a little text-based intervention, just sort of sending out some very simple CBT-focused text messages, just 1 or 2 a week, just to sort of make women mindful of, self-care and, sort of positive ways of transforming their thinking, and that sort of thing. And we found that, women really liked those things by and large. They liked being able to be screened by phone. They liked being able to do it at the time and location of their choosing. They liked receiving the text messages. Even the women who were not depressed liked getting them. And interestingly, women even said, oh, even if I have to pay for my text messages, I think it was worth it. And we didn't necessarily anticipate that we would see that. So that's something that that's encouraging to us, and we want to kind of look to other ways of expanding and building on that. One of the things that we're really excited about is our collaboration with Dr. Robert Gibbons, who's a biostatistician down at the University of Chicago. He developed a tool called the Computerized Adaptive Test for Mental Health. And essentially what he did is he took thousands of items from thousands of screens for depression, anxiety, mania, other mental health disorders, and sort of fed them into this very elegant biostatistical analysis where we can actually screen women using a relatively small number of items, but really get at very specific and sensitive information about their mood state. So we can look at not only do they screen positive for depression, but what are the odds they would meet diagnostic criteria for a major depressive disorder? And would that disorder be considered mild, moderate, or severe? Same thing with anxiety, with mania. There's a number of suicide severity indicators baked into that as well. And we worked with Dr. Gibbons to actually calibrate that tool for the perinatal population because we recognize that a lot of symptoms that apply to the general population are a little bit different among pregnant and postpartum women. So what we did is we sort of tossed out all the items that didn't differentiate well between depressed and non-depressed or manic and non-manic perinatal women. We kept the ones that did differentiate well, and we created sort of a perinatal specific version of this tool. And so that's what we're really excited about doing some more work with in the future, not only because it can screen for disorders beyond depression, but because, it can be used as a treatment tracking tool. It can give us a clue about likely diagnosis, and it's a tool that, OBs and other providers can use, perhaps they start a patient on medication and they want to know, is it working? Patients can complete this tool on a weekly basis. They're not going to get the same questions every time. It's going to be different each time. And it's really going to provide a way to see, are these symptoms improving or are they getting worse? And the way the sort of elegant biostatistics behind it works is, the way a lot of testing works these days, it's adaptive. So, the first question may be one that, differentiates depressed versus non-depressed women. And if someone answers it in the affirmative, they're going to get more questions to look at the severity of their depression. If they answer it negatively, the test might move on to tap more anxiety. So it's a very individually specific test, and it's a test that's different every time.
I know people are very excited about this, Jo, and it almost will warrant, when the time is right, to share more, a separate webinar, I think, that we can really push in a broader way. When will there be more information about that tool? And I know you've shared some great information about this work with me in the past. It does seem to be able to potentially be leveraged beyond Illinois and beyond your model. So I think there's going to be a lot of excitement about this work.
Yes, and I can provide a little bit more information now. We have published one paper related to our perinatal calibration of the tool, and I can send you that reference if you want to put that on the website as well. And then we are, sort of in the process of launching a sort of system-wide rollout of using this tool alongside the Edinburgh for a period of time at least, just to kind of, make sure it does what we want it to do. And, with the goal that this would one day become our screening tool and that it would be something that we can sort of push out to the patient via a smartphone and then have it come right back in and be incorporated into their electronic health record.
Great. Well, a lot of excitement about this tool coming, feedback coming in through the question feature. So thank you for that. And let us know how we can help speed that along if there's anything outsiders can do, Joe. That's fantastic. And one question and one conversation that's starting to happen more and more that you touched on with the use of this tool, and perhaps you have thoughts on it beyond the use of this forthcoming tool, is the importance of distinguishing between, potential psychosis or mania, catching it before it becomes a psychosis, and sort of the underlying detection of bipolar disorder, and OCD, right, which can look to a provider who perhaps isn't trained, or even a provider who's trained and is just struggling from a resource perspective. It can seem very scary if the mom is having intrusive thoughts about harming a baby. I think most of us, those on the line, have been trained and know there's a distinction. But how are you addressing the nuances of those disorders in your treatment planning work during assessments now? And it sounds to me like the tool may be able to really pick up on those nuances later, which I think will be an incredible assistance to the field.
Right, and that's one advantage we really see to using the CAT-MH, and something that we're really hoping to see come to fruition. Speaking more generally to those points, Joy, those are some of the big points that we hit on in our medical student education, because I think the biggest potential for a well-meaning healthcare provider to have things go a little awry is if they know enough to be concerned, but they don't know enough not to be overly alarmed. And so some of those distinctions between, what can look psychotic versus what's OCD, or, recognizing if someone's at a higher risk for psychosis are, some of the key training points that we put into place, because the model we sort of want to advocate for is that a primary care physician can manage a lot of this. They can manage a lot of the recognition. They can even manage a lot of the treatment, but they also need to know when it's beyond their scope of care, and they need to be able to quickly recognize those cases and refer them elsewhere. And so we really, our goal is to equip providers to know, when it's something they can, whip out their prescription pad and write a prescription for an SSRI, and when it's a matter of they really need to seek out a reproductive psychiatrist for this patient, for example. It's also a big piece of what we do in our patient education through the Moms line and through the outreach calls we make to the at-risk screening women. We're doing a lot of assessing of risk factors and history, and we'll do a lot of psychoeducation with women around their personal risk. And if we have a mom, for example, who's had a history of bipolar disorder, or who's had, perhaps a past manic episode, undiagnosed, anything like that, a family history, we will do education around, your personal risk for this disorder is higher than average. That doesn't mean it's going to happen to you, but let's talk about the safety net we can put in place if it does. Let's talk about equipping you and your loved ones to recognize it if it's something that should happen. And, we're doing the same thing with depression, with OCD, with other things. So that we're equipping providers, we're equipping patients, and we're equipping, when possible, family members to recognize and also differentiate among some of these conditions, with the overarching theme being that all of these are treatable conditions, and that, no one should be suffering in silence with any of them, and it's just a matter of accessing the right type of help.
Great. Well, people are quite excited about all of that, Joe. Thank you. And we've got a few more minutes left. Let me just ask you to highlight any more technology that you think this group should know about? I know chatbot, and there's a couple other things that you've mentioned. Want to touch on that before we wrap up? And if anyone does have any other questions, feel free to text them in or through the question feature now.
Sure. So I can just speak quickly about these other collaborations. So the chatbot is actually a study that we're about to begin with a colleague, David Beiser, who's a physician down at University of Chicago. And we're actually going to use Facebook Messenger as a way of sort of helping encourage women to adhere to depression treatment and to sort of guide them through and remind them to use the tools that are available to them. So that's something that we are pretty excited about, just because there's no literature so far on this, and it's been used effectively in some other medical patient populations, and smartphone ownership is pretty ubiquitous in our setting, and so just seeing is this tool that's in the hands of most of the women we see every day something that we can really harness to help them adhere to treatment and to just help them remember to tap the tools and resources that are available to them. Then our Mom Mood Booster collaboration, this is with Dr. Brian Danaher, who's out at the University of Oregon. He is a collaborator of Jeanette Milgram, which is a name that many on the call may recognize. So the Australian version of this is called Mom Mood Booster. The American version is Mom Mood Booster. It's a web-based CBT intervention that we are adapting for delivery via a smartphone app. And so that is something that's currently in development, but that we're hoping to test in the coming months and years.
Great. So I think what we'll do is wait to see the results of the Mom Mood Booster and collaboration, and also the chatbot work. I know there's a question about HIPAA and privacy and how does that work with these tools, especially chatbot. But why don't we wait? Or Joe, if you want to share anything about that, perhaps with me in email. And if anyone's interested in sort of HIPAA concerns and how Joe and her team are addressing those in a variety of ways, feel free to email me, joy@2020mom.org. We don't have any additional questions that have come in, but people are very impressed with your work, Joe, and applauding you from afar for this leadership. I do also, Joe, want to continue to have conversation with you relative to legislative work and statewide infrastructure in Illinois. We know, some of us have been doing this work for a while, know that Illinois is one of the first 3 states that really have gone deep around maternal mental health. And so at some point, we'll pull you back in, Joe, and have those conversations later. But with that, I think we will conclude today's webinar and fireside chat with Dr. Joe Kim at NorthShore University. Joe, thank you so much for just your ongoing leadership and commitment. And you clearly are such an important champion, using the exact right words all the time as you develop these programs. So we appreciate you so much. Thank you for your leadership.
Absolutely. Thank you so much for having me. And, just feel free to send me a list of everything that I promised you during this call, and I will follow up and send it all your way as soon as possible.
We will follow up. Thank you so much, everyone. And quickly, there's just a quick reminder here that we have another Innovation Award winner webinar coming up. We've got a couple. You can see them on the slide now, and feel free again to check out our website, 2020mom.org, and the Innovation Awards program page for more information about this program and others. And we hope to see you all soon. Thanks, everybody. Enjoy the rest of your week.